So, good morning. Welcome back to Saturday Club Morning. And today we have a very interesting topic and a very eminent speaker. We have Dr. Rajiv Bhatt, who is an alum of Tata Memorial Hospital, Mumbai, also Baroda Medical College, and is practicing as oncosurgeon here in Baroda. He pioneered the specialty in Vadodara in 1995. He had his fellowships at MSKCC, New York, and Nottingham, UK. He's a senior consultant in surgical oncology at the. He worked as a senior consultant in surgical oncology at the Krishani Bhagwanath Hospital and Wits University, Johannesburg, South Africa from 2009 to 2011. He has numerous publications, lectures, and orations to his credit. He has a vast experience of over 30 years in surgical oncology and has performed over 12,000 cancer surgeries to date. And to his credit, he has pioneered specialized breast cancer surgery in Vadodara, breast conservation surgery in 1997, and breast oncoplasty in 2010. So we have Dr. Rajiv Bhatt here. He'll be talking about recent advances in breast cancer management. So over to Rajiv.
Thank you, Satish, very much. It's a privilege to be back to the Saturday Club and a pleasure to see all the senior consultants. Takes me down memory lane and cherish very significant memories I've had with Dr. Amin, Dr. Jagdish Bhai, and all the others who are over here. So very good morning to all of you. And I will just share my screen. So I will be speaking on breast cancer. And as you know, the advances in oncology in general and breast cancer specifically are tremendous. There's an average of about 30 to 32,000 new papers published every year in breast cancer. And it's extremely difficult to pick out the significant ones and the ones which are actually practice changing in such a glut of published material. Having said that, what I would propose to do in the next few minutes is to give you a kind of an overview or a bird's eye view about how breast cancer is practiced today. And many of you will be able to appreciate and understand the changes. Dr. Amin was mentioning The Emperor of All Maladies by Siddharth Mukherjee. Very significant book, but now if he were to write a sequel to that, it would be thicker than the original book, I'm sure. So, breast cancer, as you know, is the commonest cancer in women in India. And the lifetime risk in Western countries is 1 in 8, whereas in India, it ranges between 1 in 25 to 1 in 60, depending on whether you're in an urban area or a rural area. So clearly, breast cancer in India is less common than it is in Western countries. However, the sad thing is that our mortality is much higher. And you will see that in India, we have 1 in 2 women of breast cancer who will die of their disease at some point in time. Whereas in Western countries, that is 1 in 5 or 6. So that's a 15% almost versus a 50% mortality that we have in India. The reasons, of course, for this are well known to all of us, but this is a sad state of affairs. Now, what I will do is that I will touch upon prevention and early detection first, because I think this is really the key thing in breast cancer if you want to bring down that mortality. Then I'll give an overview of breast cancer treatment. I'll talk briefly about personalized oncology as we practice it today. And finally, a short discussion on the barriers and beliefs that affect outcomes in our environment in Baroda as we practice today. So the first two questions are clearly, is breast cancer preventable? Is early detection possible? And the answer to both of these questions is yes. And the reason for that is that there is a long window of opportunity. Up to about 1 millimeter of disease is very difficult to pick up even by modern imaging methods. And in have almost about 0 to 5 years, prevention is what is going to work. Many women will die not knowing that they have an insight to cancer within their breasts. More than 1 centimeter is what is normally picked up on a clinical basis and by routine imaging. Between 1 millimeter and 1 centimeter is picked up by various imaging modalities. And this is where early detection comes in. So prevention and early detection. And this is where we have a huge window of opportunity, which we need to exercise a little more vigorously. Now, what can an individual do in terms of prevention and early detection? The first is that you need to know your own risk of contracting breast cancer, lifestyle modification, and not to neglect preventive checkups. For early detection, one needs to heed the warning signs and the body signals and seek specialist consultation early. We have now moved to an era of awareness-based early detection and risk-based screening, because mass population-based screening has its own limitations, as we all understand. So what are the risk factors? Clearly, being a female is the predominant risk factor, 100 times more chances than in males, increasing age, a family history of breast cancer, past history of certain proliferative benign breast disease, especially when associated with atypia, and increased breast density, which is seen on imaging. And there is even a gradation system for breast density, which specialist breast radiologists will usually report upon. Then the presence of the hereditary genes, BRCA1, BRCA2, and there are certain other genes also which have now been identified. The increased exposure to estrogen, meaning early menarche or late menopause, and a history of radiation exposure for whatever reason in childhood or adolescence. Now, HRT is a risk factor when taken for a prolonged period, and I'll just touch on that a little later. But high BMI and not being physically active are also now scientifically proven risk factors. The reproductive history has a role to play. If you have a late first pregnancy, not breastfeeding, nulliparity, all these are minor risk factors. And alcohol consumption, not tobacco, is clearly a proven risk factor. In terms of lifestyle modification, the first thing is that body fat. Have a healthy diet, focus on physical activity. We need to breastfeed as far as possible, at least for 6 months. Limit alcohol consumption. Avoid supplements for cancer prevention, because most of these do more harm than good. And I put these other two in a lesser color because there is no scientific proof as of yet, but it is in process. And I believe that in the years to come, we'll have more and more literature showing the relationship between yoga, pranayama, mindfulness, and the incidence of cancer in general, specifically breast cancer. And of course, the reduction of stress, because most of these will act on the psychoneuroimmunological axis, and hormones have a big role to play in that. Now, the lifestyle association with breast cancer is not something that has just happened suddenly. But we generally fall back upon this report from the World Cancer Research Fund, which analyzed 119 studies from around the world, comprising more than 12 million women and over 2.6 lakh cases of breast cancer. So there is a solid scientific basis to what I will now say with respect to the lifestyle related factors. Now, body fatness is an extremely important risk factor. And this is usually measured either by BMI, waist circumference, and waist hip ratio. And the recommendation is that all three should be taken into consideration, because each has certain limitations. But when all three are measured, you'll get an idea of the actual amount of adiposity as opposed to simple height-weight correlations that the BMI gives. Many people ask me how obesity can lead to cancer. Generally, the estrogen produced in the postmenopausal period comes from the fat cells. Gynecologists know this well. There is insulin and certain other growth factors also that are secreted by adipose cells, and inflammation that is caused by the cytokine release from dividing cells. So there are other theories, but by and large, we now know that adiposity can clearly lead to increased breast cancer incidence and recurrence as well. Just to give you an idea, a 5% increase in the postmenopausal breast cancer risk happens with every 2 kilogram per square meter increment in the BMI, which means that if you are at recommended 25 versus 30, you can have a 13% higher risk of contracting breast cancer. And this is straight mathematics, scientifically proven. But the important thing is that BMI does not distinguish between adiposity and muscle. So you can have metabolic obesity in a normal weighted person. And there is a 56% increase in the risk of developing estrogen receptor positive breast cancer per 5 kilogram increase in truncal fat, despite having a normal weight. And this is something which is very important and something which we would need to keep in mind. Now, what happens if you reduce weight? Is there an impact? Do you reduce your chances of breast recurrence? Yes, very, very true. It can reduce. The larger the change, the larger the reduction in your risk of breast cancer. But even a 2 kilogram loss has been proven to be important. But the important thing is that it should be a sustained weight loss. And another thing to note is that the reduction happens even without physical activity interventions. So it's very, very important that weight is kept in check, especially as women enter the perimenopausal and the postmenopausal period. A 5% weight loss reduction can reduce risk by almost 12%. This is the preventability estimates. When you will combine certain lifestyle factors, you can get anywhere between 27 to 38% reduction in your risk of breast cancer just by simple lifestyle modification. And this is important for prevention. Now, a quick word about menopausal hormonal therapy. We should avoid it as far as possible, but if you have to take it for medical reasons, then have it for the shortest time and the lowest dose. And because there are many. Essentially, I found in my practice that lifestyle modifications with phytoestrogens and inappropriate indications, drugs for bone loss and for hot flashes, does the job in upwards of 90-95% of women, and you will not need to consider hormone therapy at all. Now, awareness-based early detection means that you give disease-specific information and increase awareness amongst women as well as men. And it's important to give it to men as well, and I'll come to that reason a little later. So what does it involve? Breast self-examination, clinical breast examination, and you promote the self-realization of the importance of prioritizing their own health amongst women. And this is why it is important to direct this towards males as well, because women traditionally focus on family, children, if they're working, then even on their work life, and tend to neglect their own health. And this must not happen at all, because otherwise, as we see, most of the cases that we are seeing now are, stage 3 and occasionally in stage 4. And it's interesting that all these Indian studies noted that awareness about breast cancer signs and symptoms, self-examination, clinical examination varied from 16 to 41% in our country. And actually less than 10% of women actually practice breast self-examination. So there's a huge opportunity here for increasing awareness. This just shows you the average size of the lump that is detected by accident if the patient feels it herself. That's usually about 3.5 centimeters. But if one is doing regular examinations, then at 2 centimeters, a clinician can easily pick it up. And by mammography, and you do have regular mammographies, then even less than 2 centimeters, you will be able to pick up lesions quite easily. So we will advise breast self-examination to promote self-awareness every month, clinical breast examination annually from age 35, and mammography between 45 and 65 once every 2 years as a risk-directed strategy and not as a population-directed strategy. Now, coming to the treatment overview, breast cancer today we divide into 4. It's in situ, early breast cancer, locally advanced breast cancer, and metastatic breast cancer. So as far as early breast cancer is concerned, mainly it's non-palpable lesions that are picked up on incidentally on mammography, and we need to biopsy these. And for that, we use either guided core needle biopsy by ultrasound or stereotactic method, or a wire localized excision biopsy. And this shows a lady who had a breast cancer in one of her breasts. On mammography, It picked up another non-palpable lesion, guide wire was inserted, and that was biopsied and found to be a DCIS or an in situ cancer. Now, what is early breast cancer? So I'm not going to go into the staging details, but just understand that any tumor that is less than 5 centimeters and you have limited regional lymphadenopathy would qualify as an early breast cancer. And this is a separate group from locally advanced breast cancer. What do we do in terms of investigations? Essentially, it's clinical examination. This lady had a lump here at 11 o'clock position. It is seen here on bilateral mammography and ultrasonography. And then we do a core needle biopsy for histopath examination and 4 very important aspects done by immunohistochemistry, which are mandatory before deciding any treatment today for breast cancer. We will do the ERPR receptors, the HER2/neu receptor, and the Ki67, which is an index of proliferation. And I'm just putting up this conclusion on one of the mammography reports that I came across, which said that it's a BIRADS 4, which means that it is suspicious for malignancy and it needs FNAC. Now, I want to stress here that FNAC we do in only selective cases. Nowadays, a core needle biopsy is mandatory because we need to have enough tissue for this IHC available for us. And the BIRAD system actually says it needs biopsy, not FNAC. So please note that even when you have a category 4, 5, 6, whatever, you have to have a core needle biopsy and not an FNAC. Should simple excision be done? And it should not be done because it compromises treatment. And I see these kind of cases coming to me every day. Sometimes, usually it's surgeons, sometimes gynecologists who have actually taken out the lump on the assumption that it's going to be a benign lump, either because she's very young or it's a very small lump. And this compromises treatment. Now, as far as early breast cancer is concerned, the treatment sequencing is very simple. We begin with surgery. We then go on to systemic treatment, which could be chemotherapy. We may add trastuzumab if she is HER2 positive, and endocrine therapy if she is hormone receptor positive, and follow that up with radiation therapy. So this is the normal sequencing of treatment for early breast cancer. What is the standard of care as far as surgery is concerned for early breast cancer? It is now breast conservation surgery or oncoplasty. And for the axilla, it's a sentinel lymph node directed management, which we will come to. But axillary node dissection is reserved only for clinically or radiologically positive nodal cases and not for node negative cases. I get asked this question many times, is breast conservation therapy safe? Now, we've got enough evidence now with follow-ups exceeding 20 years that it is completely safe. Whether you do a mastectomy or a breast conservation, the survival does not change, provided that it is done according to the recommended parameters. When is mastectomy acceptable for early breast cancer? If there is extensive multi-site invasive or in situ disease, it is multicentric disease throughout the breast, then yes, it is acceptable. If you have a second ipsilateral in-breast event following previous breast conservation treatment, meaning a recurrence in the local ipsilateral breast, then you can do a mastectomy. If you do it as a risk reduction surgery, prophylactic basis, the classic example here is Angelina Jolie, then it would be considered acceptable. And patient choice. Now, patient choice here is mentioned, but it's very important that the treating specialist explains the options to the patient very clearly. And at this point, I find that a lot of relatives, well-meaning doctor friends advise women that, no, you must have it all out, otherwise it's going to come back, and then, we just, the surgeon says that, yes, but the patient wanted a mastectomy. My point is that, did you do enough to explain the impact of losing the breast at that age, and that saving the breast and doing appropriate surgery, in fact, will not increase her chances of a local recurrence? And if you compare this with this, the survival is equal or even better for breast conservation treatment. We now have evidence that breast conservation treatment, actually patients have a better survival, and clearly we know that the quality of life is better. This recent paper that came out, 6-year follow-up of almost 49,000 cases, when corrected for confounding factors, breast conservation offered a 5% survival benefit. So clearly advising mastectomy for early breast cancer would be considered inappropriate. Breast conservation versus mastectomy, another review of 5,600 cases for large tumors, more than 5 centimeters. There also with the 7 years of median follow-up, 16% of the patients with more than 5 centimeter tumors underwent breast conservation, and the curves completely match. There is no difference in the outcomes. So breast conserving treatment is clearly safe. It offers equal or superior survival for early breast cancer and probably for T3 tumors, meaning those even more than 5 centimeters. And now we are doing an increasing number of oncoplastic procedures for women who have even more than 5 centimeter tumors. Now, why should simple excision be not be done? You know, I again see a lot of patients where surgeons have done lumpectomies only. And just doing a simple lumpectomy is not tantamount to breast conservation surgery or oncoplastic surgery. There are certain things that need to be followed for that procedure to be accepted as current standard of care. Simple excision we don't do because it causes a lot of scarring, seroma. Post-radiation, it will cause fibrosis. And 36% of the women will fail to achieve adequate margins in a single operation, and you'll have to go back again for positive margins. And this worsens the cosmesis, and you many times have to convert to a mastectomy. This is one of my earlier cases where we were doing breast conservation surgeries alone, and you can see that even that doesn't give an ideal cosmetic outcome. There is some saucering here. This is the axillary dissection scar. So this is another patient where you can see that the symmetry is not safeguarded. Breast conservation was done with an adequate margin. Axillary dissection was done, but you get suboptimal cosmetic outcomes doing just simple breast conserving surgery. Most of our breast surgeries are oncoplastic procedures now. And what oncoplastic does that it allows rebalancing of the tissue. We either displace breast parenchyma or we replace breast parenchyma. And there are various levels of oncoplasties, but we are also now doing what we call extreme oncoplasty, where more than 50% of the breast volume is removed, and yet the breast can return to its normal shape again. I'll just show you a few simple examples that you can see. This was the lump over here. This was a parenchymal oncoplastic.
Lecture aiko yaar at the No Saturday Club.
And this is another procedure. Please understand that there are many different type of procedures that are done in oncoplasty based on where the tumor is located, how large is the tumor, what is the size of the breast. So we have an array of different procedures that we use. This is what we call an inferior pole mammoplasty. This is the lump removed with adequate margins. This is the size of the defect. We wait for the frozen section, negative, and then we reconstruct the entire nipple areolar complex and give this kind of a scar. This is another type of oncoplastic reconstruction. You can see that it gives acceptable cosmetic outcomes. Another case where you have an inferior inner pole tumor, very young woman, but we did the oncoplastic procedure with an axillary node dissection. She had a positive node. Another type of procedure for breast oncoplasty. All of these give excellent cosmetic results. Now, this is an example of extreme oncoplasty where the entire upper half of the breast we had to remove, amounting to almost about 50% plus volume resection. And we did a matching surgery on the opposite side. And this is the outcome post-operatively as well. And we had adequate margins. This is another procedure, a round block with an axillary node dissection. You can see there is a good symmetry now. We just do a periareolar incision, which you can hardly see. This is the small sentinel lymph node incision that we have made in the axilla. She was node negative. Another example of a lower inner quadrant with SLMB. The scar is along here and is hardly visible now in the inferior crease. This was the sentinel lymph node scar, about 2 centimeters long. Even after radiation, we still continue to have very good cosmetic results. So our experience actually in HCG, I have just put up here to let you appreciate that we now do more breast conservations and oncoplasties in 2021. This is the data till November. And you can see that when we started, it was more mastectomies, which is the blue. And gradually, now we are doing more and more breast oncoplastic and breast conservation surgeries in 2021. Now, what about the axilla? The axilla, I think the recommendations are very clear. We need to understand that if you have positive axillary nodes clinically or radiologically, you have to undergo an axillary node dissection. There is no question there, and we just remove levels 1 and 2. The problem with axillary node dissection is that there are a lot of complications: shoulder pain, impaired movements, numbness if you don't preserve the intercostal brachial nerves, repeated seroma aspirations, and the most dreaded one of lymphedema in 20 to 40% of cases. And that's why for negative nodes, now why should these women be exposed to these kind of complications when the nodes are negative? And for that, we do a sentinel lymph node directed management, which I will just come to. We just remove 2 to 4 sentinel lymph nodes, submit them for frozen section. If they are positive, then we proceed to full axillary dissection. If not, then we stop there. This is the lymphedema that we so distressingly see in follow-up. Usually happens around the 2nd, 3rd year. Now, sentinel lymph node biopsy, the concept is very simple. You see, the breast lymphatics drain from the periareolar complex to a sentinel lymph node, which is the first echelon lymph node. It's a seed. What we do is that with a proper tracer, we pick up this node and submit that for frozen. If this is negative, then it is unlikely that the subsequent level nodes are going to be positive. And traditionally, we were using radioactive colloid that necessitated a gamma camera and a Geiger counter for picking up the node. But at HCG now we're using ICG, which has made life extremely simple, and we can do this in the theater itself. What we do is a handheld camera, and we inject indocyanine green. This is the instrument that we are using, and this is the lymph node. This is the area of marking in the crease for the sentinel lymph node. This is the camera, and you can see on the screen over here that it shows up as a white, and this is the lymph node. We dissect right there, and it shows up over here, and we pick up that and send that for frozen section. And this is the injection, and this is how it goes to the lymphatic here into the axilla. That's the lymph node that we pick up, and that's the extracted lymph node confirmed again. Now, I'll just show you. This is the injection of the node of the dye, and you can see it going to the axilla over here. This is, in fact, radio-guided surgery. This is fluorescent radio-guided surgery, and we put a small incision over here and pick up the lymph node, and you can see it brilliantly lighting up over here. So we dissect just around that lymph node and pick it up, and once it's out, we confirm with the camera again that it is lighting up, so that we know that it is the sentinel lymph node. If it is not lighting up, then it's not a sentinel lymph node. And then this is submitted for frozen section. So this is radio-guided surgery, ICG radio-guided surgery that happens in real time and significantly reduces the morbidity of axillary lymph node dissection. To date, we have done 84 sentinel lymph nodes. The majority of them have been in oncoplastic procedures, 71, 2 of them mastectomies, and in 11 cases, we had to convert it to an axillary lymph node dissection because on frozen section, the lymph node was positive. Now, the adjuvant treatment in terms of chemotherapy and radiotherapy is very important. It's based on a lot of factors, and the sequencing also is important. And this is where now we have understood the biology of breast cancer much, much better. And now we treat according to the molecular subtypes. No longer do we treat according to stage or nodal involvement. I mean, those factors are certainly important. But now our treatment is generally guided by the molecular subtypes, because we need to individualize the treatment based on the biology of the tumor and not do a blanket treatment for all women. So just to give you an idea, I won't go into a lot of details, but there are essentially 3 types of molecular subtypes. The first is divided into luminal A and B, which is the hormone receptor positive group, ERPR positive group. The second is the HER2 positive, hormone receptor negative group. And the third is the triple negative, meaning hormone receptors are negative and HER2 new receptor is also negative. And this subgroup clearly has the worst prognosis. This is intermediate, And luminal A and B refers to HER2 positive, but hormone receptor positive as well. And luminal A is hormone receptor positive and HER2 negative. And this is the best subgroup. In fact, in these cases, we have now started to de-escalate and omit chemotherapy as adjuvant treatment to avoid the side effects. So now we are trying to individualize treatment and give the appropriate treatment. And now, of course, the mortality is clearly linked to the molecular subtypes. You can see here the two subtypes, triple negative and HER2 positive versus hormone receptor positive. Clearly inferior survival, and that continues even if it is lymph node negative or it is lymph node positive. So the lymph node status is relatively less important than the molecular subtype now in terms of the prognosis and in terms of selection of treatment. Now, locally advanced breast cancer, bulky invasive disease, you may have skin involvement or chest wall involvement, and you would have extensive lymph node involvement. This is locally advanced breast cancer. Currently, we are seeing about 50% of our cases coming in as locally advanced, 50-60% coming in as locally advanced breast cancers. We have two options here. One is to go with primary surgery like early breast cancer. The other is to go for primary systemic treatment or to give neoadjuvant treatment up front, then do surgery and follow it up with radiation therapy. I need to stress here that whenever we save the breast, we have to radiate that ipsilateral breast without question. The initial assessment in these patients is by mammography, core needle biopsy, like we said, but in addition, we put in a clip into the primary tumor because we have often found that giving neoadjuvant systemic treatment sometimes causes complete disappearance of the tumor, and then we don't know what to excise when we go back in. As far as imaging is concerned, our preference is for doing a PET CT scan. We place a clip in the axillary lymph node as well. The yield of a PET CT scan is 14 to 30% in terms of identifying asymptomatic metastases, which would mandate treatment change. So primary surgery versus neoadjuvant systemic treatment, it could be chemotherapy, it could be endocrine treatment. A lot of my older aged patients, we tend to give endocrine treatment rather than chemotherapy for obvious reasons. And there are advantages of neoadjuvant chemotherapy. Downsizes the tumor. We can do breast conservation now, whereas previously we would have had to do a mastectomy. It allows us to prognosticate in terms of the response pathologically to our neoadjuvant treatment, and to change the treatment if the response hasn't been adequate. And this is, it's like an in vivo testing of the efficacy of your systemic treatment. And this is actually used now as a surrogate marker for a lot of the trials. The pathological complete response is used as a surrogate marker for a lot of the trials now, so that the trials can finish much earlier and in relatively lesser sample sizes. And again, we have options post neoadjuvant chemotherapy for breast conservation versus mastectomy. Is breast conservation safe after neoadjuvant chemotherapy? Yes, it's completely safe. Once again, adequate evidence is there. 8 trials, there's absolutely no difference in outcomes. This is a PRISMA compliant systematic review, which also shows that there is a higher overall survival and a higher DFS in patients who had breast conservation versus those who had mastectomy. 20 to 40% of women who will have neoadjuvant treatment will now be candidates for breast conservation as compared to mastectomy prior to the treatment. And clearly, biology and the responsiveness to the neoadjuvant treatment now is more relevant than tumor stage. What we look for is what we call PCR, pathological complete response in both the breast and the lymph nodes, and that happens in 30 to 20% of patients. And those who have this response clearly will do much, much better than those who do not have a pathological complete response. Surprisingly, the pathological complete response for HER2 positive and triple negative breast cancers is much higher than for hormone receptor positive breast cancers. So here again, the molecular subtype guides treatment. For hormone receptor positive women, we tend to do primary surgery. But for these two subgroups now, we would advocate neoadjuvant treatment before doing surgery. I get asked this question all the time. If there is a complete response, then can we omit the surgery? And the simple answer to that is no, because 30 to 50% will still have residual tumor on histopath examination. So we cannot omit surgery following complete response. What happens as a surgeon, we find difficulty about where the tumor is it removed? Is that area removed for pathology? And there is a very rigorous methodology that we have to follow. We have to mark it properly, orient it, do specimen mammographies, do a frozen section. The pathologist must be well versed in doing the shave margins. And you can see here this, we've localized, we put a clip here in a patient who was a candidate for neoadjuvant chemotherapy. And after NSCT, the mass disappears, but the lesion is still marked with the clip. And this is then excised. We confirm with specimen mammography that that clip has actually been excised and that there looks to be adequate margins. And then that is again confirmed by frozen section. This shows another case. Over here, the clip is placed and then the clip is fully excised. Orient it properly, mark it for the frozen section, because negative margins is a basic prerequisite. And we know that it's a major factor for recurrence if you don't achieve negative margins. Most of these local recurrences will occur in the first 4 years. And again, adequate evidence that if you can prevent 4 local recurrences, then you will avoid one breast cancer death over a 15-year period. So local recurrence is extremely important. And that's where methodology comes in. This is the impact of neoadjuvant treatment. This patient had a huge tumor, neoadjuvant treatment shrunken, and then she subsequently underwent surgery. So dramatic responses to neoadjuvant systemic treatment. Now, this is an actual case example. You see a huge tumor over here. This is the PET CT scan. This is the tumor visible, and you will see also lymph nodes. You'll see internal mammary lymph nodes. And the biopsy showed it to be hormone responsive, positive, and HER2 receptor positive as well. And she had a fairly high proliferative index. She was given neoadjuvant chemotherapy. And this was the pre-PET. This is the post-PET showing hardly any uptake. And she underwent surgery with a DIEP flap. This is a microvascular free flap reconstruction. And the final pathology report did show residual tumor, because remember that she was hormone receptor positive. So you have a mixed cell population over there, which is varyingly sensitive to the chemotherapy. She underwent radiotherapy and endocrine therapy thereafter. Another case, a young woman who had a triple negative breast cancer. And this was the pre, this was the post pictures. You can see that the lump is seen here, hardly seen there. She underwent oncoplastic conservation breast surgery, and this was the pathology report, which showed only microscopic tumor remaining in the final report. And she also underwent an oncoplasty, and this is the post-radiation therapy outcome. We often use latissimus dorsi flaps to reconstruct if you have thin breast, small volume breasts, or you have a large volume resection in a moderate sized breast. Radiation therapy, as I said, is mandatory after breast conservation, but occasionally after mastectomy also we need to do it, especially if the tumor is more than 5 centimeters or the nodes are positive. Now, finally coming to metastatic breast cancer, and we know that most of the deaths worldwide are due to metastatic breast cancer as far as breast cancer is concerned. And in developed countries, 20 to 30% of patients with early breast cancer will subsequently develop metastases. And this number is clearly going to be much higher in developing countries. And traditionally, the median survival used to be 2 to 3 years with very little improvement in the last 5 years. And you can see this match of the previous decade and the decade after the turn of the century. Hardly any change in terms of the outcomes. But what is interesting is that there is a great variation in terms of the molecular subtype. And this is very clearly shown. So that now we know that for certain molecular subtypes, we can treat a little more aggressively in the metastatic setting with expectation of good outcomes. Even the molecular subtypes will determine to which organ the spread is likely to occur. And there is a varying propensity for spread based on whether it's luminal A, B, or HER2 enriched or a triple negative. Traditionally, we used to think metastatic disease means end of life care, that it's not curable. All metastatic disease is the same. The patient is metastatic, so we'll just give palliative treatment. This is now very far from the truth in today's day in practice. And the reason is that it's not that simple to get metastasis, because many events must take place. The tumor cells must survive the host defenses. they must survive circulatory turbulence, and then they must survive the secondary effects at the metastatic site for it to actually develop into a full-blown metastatic tumor. So it's not necessary that even if cells do circulate, we pick up circulating tumor cells, that metastasis will 100% happen. Although it is an indication, but it's not necessary. Is metastatic cancer curable, breast cancer? Yes. And these are the SEER result statistics. And you can see that 26% will have a 5-year survival, even though metastatic. So I'll just give you a case example of how we pick up certain metastatic breast cancers for aggressive treatment. This was a 62-year-old lady who had a lump with a palpable axillary node, and she underwent a core needle biopsy, and she was a HER2 positive, hormone receptor negative. Routine ultrasound showed a lesion in the right lobe of the liver, and this was the scan. The liver biopsy showed metastatic adenocarcinoma. So she had asymptomatic liver metastases, right? Single site, and we call this as oligometastatic disease. But since it was metastatic, we started her on chemotherapy. She had this particular schedule of chemotherapy, and post chemotherapy, there was a almost complete disappearance of the lesion in the liver. She underwent breast conservation surgery, and very little residual tumor was left behind, just 1 centimeter residual tumor. But remember that the liver lesion had totally disappeared. So what would you do next? Would you do anything for that liver lesion? We suggested that she undergo a hepatic resection to encompass the area of the previous tumor, but she wasn't really very willing to do that. She completed her 12 months of trastuzumab in 2017, and this was the scan, completely normal post trastuzumab. And then 1 year later, she comes back with expectedly recurrence of the hepatic lesion. And this clearly outlines how a radiological response does not necessarily convert to a pathological complete response. So at this point in time, then we again checked the status of the receptors, hormone receptor positive, HER2 positive. She underwent chemotherapy, and after chemotherapy, there was resolution of the metabolic activity with the regression of the lesions in hepatic segments 5 and 6. And in breast and axilla, there were it was completely without any evidence of disease. There was no new lesion. So at this point, we advised her again to undergo a hepatic resection, which she agreed. And we did a right hepatictomy with portal lymphadenectomy. This is a local ablative treatment. We put her onto tablet anastrozole. This was 2019. She's been on regular 3-monthly follow-up since then. And this is her latest scan in September of 2021. The liver has hypertrophy to compensate, but there is clearly no evidence of disease. So there is room for aggressive treatment in selected populations. This is another example which showed multiple liver lesions disappeared with neoadjuvant chemotherapy. She declined to undergo liver surgery, only breast, and the same lady that I showed you for conservation breast. And then she comes back with extensive liver disease, and she was on palliative treatment after that. So clearly all metastatic disease is not the same. We now know that there is a category called oligometastatic disease, limited disease, 1 to 5 lesions confined to a single organ or 1 to 3 organs. This is oligometastatic disease. And here we have the option of doing ablative treatment, either surgery or stereotactic radiotherapy. And there is clearly here some synergism with immunotherapy. We do see an abscopal effect sometimes. So ablative local treatment in selected cases is recommended. And this is where tumor board decisions are extremely important. Now, treatment is individualized, and we are in an era of precision oncology where tumor board decisions are extremely important. Most of our cases will undergo a proper discussion at the MDT meeting, and we ensure that we give the right care to the right patient at the right time. And this is extremely important for breast cancer with so many options, as you can see, at all possible stages. What we are trying to do is to intensify treatment in certain cases and de-escalate treatment in certain other cases where it is not needed to avoid these side effects. And examples of these we have already seen. a sentinel lymph node biopsy would be considered as a de-escalation of the treatment. Omission of chemotherapy would be considered de-escalation for hormone receptor positive early breast cancer. Dual targeting with anti-HER2 agents would be considered as intensification. So this is extremely important, and it's a recurring theme in oncology nowadays. Intensify where required, de-escalate in other situations where not required. Now, finally, what are the beliefs and barriers to good outcomes that I have seen in my practice? Most of the times it's poor biopsy technique or poor surgery. I get a lot of women who, now this is a mammography, very clearly a very large lesion, and who has undergone this kind of a surgery. I don't know whether it was a lumpectomy for diagnosis or it was a breast conservation surgery, but it really doesn't serve the purpose. This was a so-called breast conservation surgery, mastectomy, very difficult to see the scar extending throughout the chest wall. Another case here, very clearly seen lesion, very diffuse, would have been a candidate for neoadjuvant treatment, but has undergone surgery because she went, lumpectomy was done for diagnosis. Another similar case where inappropriate surgery. Can't really understand whether this was a biopsy technique or a breast conservation. I mean, the other thing is advising primary surgery in all cases, taking mastectomy as the gold standard, axillary lymph node dissection in all cases. This is now history. Patients have to be selected on individual basis, no question about it. And why do people still undergo mastectomy? And the answer is it's just fear. It is pure fear, nothing else. Fear that is instilled by what they believe, what is read, what certain well-meaning relatives will say, what certain doctors will say, that it is much better to have it out. But as far as I am concerned, fear is not a good indication for mutilating surgery. Certainly not in today's day and age. Now we will treat biologically more than anatomically. And this is again a big barrier because women who are candidates for neoadjuvant treatment often get operated straight away, depriving them of the benefit of neoadjuvant treatment. In conclusion, I'll just like to end that, now I believe we are not treating breast cancer. We are treating women. And this is something that we have to keep in mind whenever we are treating breast cancer. Thank you very much for your attention. And I will just hand over to Satish for taking the program further. Satish.
Thank you, Rajiv. That was wonderful. An eye-opener for a person like me who is a pediatrician, has not known much about breast cancer apart from what I learned during my residency.
Yeah.
So it was really an eye-opener as to how much progress has been made in the management of breast cancer. I'll start with one or two questions. This molecular diagnosis which you mentioned about breast cancer, is it applicable to all other cancers too?
In terms of determining the sequencing of treatment, yes, in a lot of cancers. I mean, we now do it for lung cancer. There are so many molecular subtypes over there and so many targets that the medical oncologist can hit that we mandate molecular subtyping for lung cancers as well. For a lot of the other cancers, it is still just a pathological confirmation and not necessarily pre-surgical molecular subtyping.
Last few slides, I could see that a lot of mismanagement has, when you did not use the word mismanagement, but it was obviously, something was really missing about proper management. So how do you, SCG, I believe you can tell something about SCG also, how big the chain of hospitals it is, and as a director of the SCG, what preventive measures are you, public education, community education about early detection and proper management? You can share.
So, the thing is that the simplest way is to just educate. And a lot of us doctors are directly hitting society, women's group of companies, for example, or out in the society and just giving lectures to lay people. I think that's the only way that we have been actually able to reach. And of course, having CMEs with doctors does help, but I have found that targeting women directly because they are interested. They want to know about their health. And I find them to be an extremely receptive audience. And we are doing this off and on. it is extremely distressing when we see women with this kind of presentation. And I have sometimes taken recourse to talking with the doctor who treated in good faith. It's often not taken well. But anyway, I think, these are the things that we are doing. See, in Breast Cancer Awareness Month, we do a lot of things that will attract people to the concept of increased awareness. Like we do this Pinktober, we lighted up all the monuments in October, our World Heritage monuments and all that, in Baroda. So, these are the various ways that we can draw attention to not neglecting the health of women. But I think ultimately it's just a one-to-one direct conversation and interactions like these, I think, which will help and make a difference and an impact.
Tell us something about HCG.
HCG, as you know, it's a network which has a hub and a spoke model. Its hub is in Bangalore, and it was initiated by a radiation oncologist, Dr. Ajay Kumar. And he subsequently developed almost now close to 25 centers around the country, including multi-specialties. But oncology centers are about 17. And out of these 17, there are 6 or 7 which work on a partnership model, of which Baroda is one. And this model works well because it allows for people like me who don't have the resources to put up such a comprehensive center, and for HCG as a network to get local oncologists involved so that they can drive the local center and capitalize on the infrastructure and the facilities available. But what it has done for, I think, me, and I think in Baroda in particular, is that, we mandate a multidisciplinary team approach to every cancer. We have our tumor board meetings every day, and this has helped a lot in trying to bridge the gaps between subspecialties and in trying to educate patients and doctors about the importance of a multidisciplinary integrated treatment in oncology today. And I think this was what seriously lacking when I was practicing as an individual attached to multiple hospitals. We would have impromptu tumor boards where we would pick up the phone, and I would often talk to, say, Pradeep Bhai, or I would talk to the radiation oncologist. But these were nowhere near the kind of formal tumor boards that we are now conducting. And I think that has helped a lot. And this is where I think HCG has had its biggest contribution.
Thank you for that information, because this is very useful for the audience we have here. It's a heterogeneous audience that we have. This kind of information helps us to guide the patients who come in our contact.
And Satish, we often invite the involved family physician or consultant to come and join us in the tumor board, and be part of the discussion. And I believe there are 1 or 2 people in the audience too who have had that opportunity. But I would encourage that, if you have any relative patient who's there, then we would more than welcome you to come and join us in the tumor board to be part of that decision-making process.
So that's a great team approach. I think that is how we should treat all the patients. Now the meeting is open for others' comments and questions.
Yeah. I think a lot of change has occurred, Rajiv, in the management.
True.
From the time we used to practice.
Yes. And that's why I said that, if Siddharth was to write again, it would be a huge book again,
That's right. How early cases now you find at younger age?
Yeah, we are seeing women in the 20s and 30s who are coming in with breast cancer. Clearly, the biggest group is the perimenopausal and the postmenopausal. But we are seeing an increasing number of women at younger age coming in, especially in that 4th decade, 30s. Early 30s, I'm seeing an increasing number of women coming. And there again, I mean, I've been asked this: why does it happen? Why do women? And I think there is some impact of lifestyle and interaction with the individual's hormonal status and levels. And we tend to underestimate the impact that our lifestyle has on the hormonal milieu inside, and how conducive it would be for external, not external, but our own cells to proliferate the wrong way.
The impact of stressful
Yeah, that's what I say.
incidence in life.
Yes, I think this is extremely important. Now, if you look for robust scientific evidence, as of today, we are unlikely to find it. But whenever I question my patients, I always find that within the preceding year or two, there has been some major stressful events in their life. Now, I cannot correlate that with what has happened, but clearly it is there. Somebody, a death, unexpected death was there, financial crisis was there, unhappy marriage, or children going the wrong way. These are the common things which people face day in, day out. But when persistent over a period of time, I think does cause a deleterious effect.
I read an interesting book, Biology of Belief, and how the stressful events changes the genetic structure. Yeah,
I call it epigenetics.
Epigenetics, that's right. And I think there is a lot more to this as Western medicine will discover with its robust methodology and framework. That is actually becoming a bit of a limitation for us, because we are supposed to demonstrate it by a scientific experiment so it can be replicated. And this is not something that is easy to do when you're considering factors that are not material factors.
Okay, so thank you, Rajiv, again for coming back to Saturday Club after a period of about 3-4 years. I think you had a talk in Saturday Club some years back.
Yeah, that was, I think it's more than that. I think 2015-16 was the last.
Yeah, I think it was after you returned back from
South Africa.
Yes. So it was a pleasure having you again with us.
So
and we look forward to some other talks in future also. Not only you, but from your team also, your tumor board, which you talked about. We'd like to know more about other cancers and their management also.
It would be a privilege.
Yeah. So thank you all. We meet again. Maybe next Saturday we'll not be having the meeting because of the festival of Makar Sankranti following day, what we call as Vasi Uttaran.
Yeah.
So we'll not have that meeting next Saturday. Again, we'll have the other Saturday. So thank you all. We meet again. Thank you.